Okay, here we go. So we're going to talk about pulmonary embolisms in this video. So pulmonary embolism is a collection of particles. It can be solid, liquid, or air that enters the venous system. So in your lungs, it's not something that's like in your lungs, but it's in the circulation that goes to and from your lungs. So it lodges in a pulmonary vessel. So it's not like something like inside your like bronchioles in your lungs, but it's in the vessels, the blood vessels that are intertwined in your lungs. So it can be caused by like a blood clot, like a DVT travels to your lungs. It causes a pulmonary embolism. That's very popular or very common. A fat embolism, which is, it can be from like after an orthosurgery or a fracture of a long bone that can travel into and block because your lungs have such tiny capillaries that things get lodged there very quickly and very easily. It can be an air bubble, like if you put in a central line and you nicked something and an air bubble went into those vessels, it can cause that. Or like broken IV, like when you take out an IV and you know how you always assess it to make sure it's intact. If it's not intact, it can lodge there as well. So what happens? So a DVT or some kind of particle breaks off, travels through the vena cava to the right side of the heart. From the right side of the heart, it goes from like the right atrium, right ventricle, through the pulmonary system, and then it lodges in the pulmonary artery of one of your branches, decreased or eliminating the blood flow to that portion of the lung. So this is a really good picture. It traveled from the heart to a pulmonary artery and it wedged there. It's not in your lung, it's in an artery that feeds blood to this part of the lung. So if it's lodged here, all of this does not get blood flow. A collection of platelets or an embolism. It can trigger the release of hormones, and that causes vasoconstriction. So a widespread pulmonary vessel constriction. It's like pulmonary hypertension. It's an impaired gas exchange. It decreases the amount of oxygen or perfusion you get to wherever it lodged in there, wherever it decided to lodge. Anything after that does not get blood supply. The artery is blocked. The artery is not feeding anything else below it. So it can cause death, impaired, or compared to an MI of the lung. So you know how when you have like a massive heart attack, like an MI, myocardial infarction, it is a blockage inside one of your heart vessels. So your left ventricle goes out and then some of that blood comes back to feed your heart. So when you have a blockage in that, that's an MI. But when you have a blockage in the arteries that feed the blood supply to your lungs, it's a PE. So signs and symptoms. So sudden onset of shortness of breath. So I know sometimes people are like, I'm having a heart attack, it's shortness of breath. This is a sudden onset of shortness of breath. Sharp stabbing chest pain. Anxiety, restlessness, feeling of doom. We've heard that in like MIs, PEs, that feeling of doom. I'm going to die. Something's wrong. People get that when something serious is happening. A cough. There can be extra pressure, decreasing O2 stat because you're not getting that oxygen to your lung. You're not getting that blood supply to your lungs. So the blood that usually goes to your lungs to get rid of CO2 and get back oxygen to circulate is not happening wherever it decided to lodge below that point. Tachycardia, decreased blood pressure, crackles, you can hear pleural friction rub. S3, S4 beats may be present as well. Diaphoresis, like sweating, and then petechiae of your chest. So, there's that one. So, risks and associated conditions. So, people who are higher risk to get a PE. So, if you do like any kind of central line or art line, it is directly into your heart. So if something breaks off or something goes in there that shouldn't go in there, it can go from your right heart into your lungs very easily. History of blood clots, conditions that increase blood clotting. Smoking, estrogen therapy, so like if you're on birth control, you're always at a higher risk for clots. History of leukemia, trauma, any surgery, advancing age. Like I know some people like who are older just experience more adverse issues, and this is one of them, and obesity, because obesity can compress your venous return. So if you're obese and you are just having like blood pool in your legs, blood pooling is always going to be a bad thing for clots to form. So the impact of a PE, how much perfusion is maintained. So if it's a big clot or if it's a big obstruction and it wedges itself in the worst position ever, and it's right here where it can't feed any part of your lung. It's in like that main artery that goes to whichever side. Or you can have, it's called saddles in the middle, but we'll talk about that in a minute. If there is no perfusion maintained to that side of your lung, bad things are going to happen. Embolus of infarction causes tissue death distal to the clot. So like I said, like she's using the word distal, but below. So wherever it decides to lodge it, like here's your heart, and then your arteries. So if it decides to lodge here, nothing is getting perfused distal or below, or just think of like this. Like if it wedges here, none of it's getting perfused. If it wedges like here, then this is still getting perfused, but nothing after this point is getting perfused. Massive PE occludes a major part of your pulmonary. Okay, so this is that saddle emboli I was talking about. It can be in the main pulmonary circulation obstruction. So it's infarction of both your lungs. So you can have like, here's your heart, and then here's your arteries that go to both of your lungs. It can happen right here and block both of those. So it's a mismatch of ventilation and perfusion. You're breathing fine. I know we don't like that word. They're going to be short of breath, chest pain, but they're getting oxygen, or they're getting air into their lungs, but you're not getting perfused whatsoever. None of that oxygen is getting into your bloodstream because you have a huge embolus or clot here, and it's not perfusing this way. Does that make sense? I know it usually goes here. It's here, and it's not perfusing at all that way. Cool. So diagnosis of a PE, she has a triple starred and bolded. So pulmonary angiography. So you can do like CTs, or they can do like ventilation or perfusion studies. That's a good one. Chest X-ray can do looking for alternative diagnoses. Labs, D-dimer. D-dimer is high. If your D-dimer is high, it's always going to be indicative of a clot. Or a potential clot, not a diagnosis for a PE. So if you have a high D-dimer, it doesn't mean, oh, she has a PE. It could mean like she has a DVT, or she just has extra clotting factors. If it's normal or low, you can rule out a clot, but if it's high, other diagnostic testing is needed to confirm. So ABGs are not always indicative of a clot either, but they can be helpful to point towards something that you need to be looking into. Hypoxia causes hyperventilation. So because you have a PE somewhere in your lungs and you're not getting perfusion, you're not picking up that oxygen that's in your lungs through the capillaries. So you're going to have a decreased amount of O2. So you're going to be hypoxic. Hypoxic initially causes hyperventilation, and that can lead to respiratory alkalosis. So if your patient is in respiratory alkalosis and you're like, I don't know what's happening, they say they're having chest pain, that can be like, oh, hint, you need to go look for somewhere else, because you need to go look at all your other testing because something is going on. Then your partial pressure of oxygen is decreased as a result of blood shunting to the left side without picking up O2 from your lungs, just what we talked about. If you're not having perfusion to that side and you're still having oxygen, but it's not being picked up picked up the O2 there, then it's not going to circulate. But then after this shunting happens, it results in respiratory acidosis. So early stages is going to be alkalosis because it's hypoxic, and then later stages it's going to be respiratory acidosis. Management, O2, never a bad idea. Sit the head of the bed up, throw some O2 on them. Watch their vitals, watch their O2 like pulse ox. If severely hypoxic, they may need to be mechanically ventilated. So if you want to, sometimes people can do like CPAPs, like positive pressure, or some people intubate. It just depends. But if they're not having perfusion, like if it's a saddle, dude, they're not getting any perfusion. But if it's like somewhere over here with it, you can get 100% oxygen to what is being perfused, then it's going to increase their outcome. So monitor vital signs, check lung sounds, cardiac monitoring. So drugs, you can do like thrombolytic therapy, but check it with their history. If they have a history of like a lot of bleeding, it may be contraindicated. Anticoagulants begin immediately to prevent the enlargement. So anticoagulants won't break up the clot, but it'll stop the clot from growing. And then maybe you can use that like fibrolytic or thrombolytic therapy to break that up. Surgery, embolectomy, so when they take out whatever's causing that. And then inferior vena cava filter. So if they have known like, oh, I always get PEs and they always go, or I always get DVTs and they always go to PEs, they might put like a filter in your inferior vena cava or superior. They might do both. And that will allow blood to still go through to your right atrium and right ventricle, that whole process, but it'll stop the clots from going as well. So in my next video, I'm just going to talk about like anticoagulants and different medications that you can use.